Hello, everyone, and thank you for joining us. My name is Laurel Page, and I'm the Assistant Director of Events at the University of Colorado Boulder's Lead School of Business. Welcome back to our 6th COVID-19 webinar series. These continue to be trying times, and here at CU Boulder, we have gathered our world-renowned faculty and alumni to provide frank and timely insights for life during the COVID-19 pandemic. Today is the 5th of 6 webinars in this COVID-19 related webinar series. To view upcoming webinars, please visit colorado.edu/business/alumni, click the drop-down arrow, and click Attend Online Webinars. For today's webinar, we're excited to welcome Associate Professor David Bortz, here presenting COVID-19 in the state of Colorado, models, warnings, and protecting our neighbors. A few housekeeping items before we begin. If you have any questions now or during the presentation that you would like to ask David, please send a question through the Q&A interface. We will monitor questions as they are submitted, and David will respond to them at the end of the presentation. As a reminder, for optimum audio quality, we do have everyone on mute except for myself and our speaker. If you experience any technical difficulties during the webinar, please notify us through the chat interface and one of our support specialists will touch base. Lastly, a link to access the webinar recording will be sent to all registrants tomorrow, along with a survey link and supplemental resources from today's presentation. Now I am excited to introduce today's speaker. David Bortz is an associate professor at the University of Colorado, Boulder, in the Department of Applied Mathematics. His research is in mathematical biology, specifically population dynamics, infectious diseases, and methodologies for model creation and analysis in the biological sciences. He has collaborated with epidemiologists, physicians, biochemists, microbiologists, and bioengineers, and has been supported by NSF, NIH, DOD, DOE, and NVIDIA. Prior to his 2006 appointment at CU Boulder, Dr. Bortz was a postdoctoral assistant professor in the mathematics department at the University of Michigan, Ann Arbor. Before that, Dr. Bortz earned a PhD from North Carolina State University in Applied Mathematics and a BA from Rice University in Computer and Applied Mathematics. Welcome, David, and thank you so much for being here. I'm going to hand the webinar controls to you now.
Okay. Thank you very much for inviting me to give a presentation here. This has been quite a interesting year so far. Back in March, when the first signs of the pandemic started, the governor, who has been very data-driven in his entire approach to this, tasked the Colorado School of Public Health to put together a team of modelers to try to give us an idea about what was going on, what the trajectories look like, what would various mitigations look like, what levers were possible, and what the overall dynamics and forecasting for the state of Colorado was going to be. Just provide information so then that they could synthesize that with what the economists were telling them, what the finances for the state, and so on. And so today I'm going to talk about both broadly the pandemic to see where we came from, how did we get here, where we are right now, and where are we headed. Without further ado, I'm going to just start going forward. So here's the overall outline. Of course, these main ideas of how we got here and where we are and such. But I want to talk about a little bit of the history of math epidemiology and what happened in Colorado specifically. I'm actually going to talk, I'm from an applied math department, so I'll throw a few equations in here. So if you have some sort of those types of trainings, hopefully you'll appreciate the analysis that we've done. But in general, I'll focus much more on the actual data and the trajectories that you can see looking at the state databases and such. And then we'll go through, what actually we're modeling in the state of Colorado, where what we've been successful at doing, and where we're headed. And just sort of a little teaser, where our models actually have been, I think, underreported in terms of how good we've gotten. We're been able to hit within 40 hospitalizations for 2-week to 4-week projections in the future. We're actually doing pretty good considering how many hospitalizations we have had over the entire time course. So anyway, let's see. So how did we get here? So just a little history, back, 1,000 years ago, roughly, basically last year, the first known infection, we have identified the first known infection. There's some evidence that it could have been circulating earlier, but right now, the first one was in mid-November last year in Wuhan, of course. And then they started seeing hospitalizations with this acute respiratory distress and diseases in late December. And so, of course, there was physicians that became very concerned about this. Didn't really coincide with what they understood about the progression for like the flu, for example, in terms of symptoms. And then by January 2nd, there was 41 cases identified. First cases outside of China were on the 13th. And when they started seeing some of these sort of the numbers coming out of Wuhan, the Imperial College has a mathematical, it's basically just an epidemiology group, and there's a mathematical epidemiology part to it. And they started running some simulations and numbers. I'll talk about those a little bit later, but they identified that this could be a huge sort of catastrophic problem. And so they posted their first report January 17th that sort of started to prod governments around the world to take this seriously. Back in China, there was, 500, almost 600 cases in 25 provinces that were identified, so it clearly was spreading. And the first European case was identified on January 25th. So we, 7,000, almost 8,000 cases, and then the first US case, which most of our cases were actually imported from Europe. So even though there was some travel bans that were a little bit leaky, there were still several thousand people going back and forth between the US and China. Most of our cases came from people in Europe, and actually in Colorado, it came from people in Australia, as far as we can tell. February was to be blunt, was not a good month if you're trying to be preventative about these things. There was identifications of 37 cases in 37 different countries. And basically, first week of March is when the Colorado reports found their reported 2 cases. There's they went back through some of the data analysis, and they have some candidates that probably were it was probably circulating in the ski resorts in mid-February here. And from there was actually an Australian, I think a dentist, and a few of his friends were skiing in various ski resorts around the world, and asymptomatically brought it here and started circulating in Colorado, and came from the counties upslope to down into Denver, and then started to the general population. Quickly, CU moved the instructions online when it became clear that this was going to be a big deal, and it was not going away. And then, on the 19th, just a week or so later, the governor ordered bars, restaurants, theaters closed, and we sort of course, this results in the surging sales of guns, toilet paper, and hand sanitizer, as we all know. And then 25th, they implement the stay-at-home order. Safer at home. So this is sort of, we of course we all lived through this, but it's important to remember that this was developing in very fast in terms of epidemics and spreading, and having to make decisions about what to shut down and when to shut down. And then, of course, since April 26th, after this, the state has implemented a sort of protocol for different levels of closing things down and keeping people safe. And then, unfortunately, this has been able to keep it down and controlled for most of the summer. But as we've gotten into the fall, there's a variety of it's a very multifaceted reason, but we are really on an upswing now, and so we have to be very careful about what's going on. And in terms of the choices, in terms of how you choose what level the Colorado is choosing on this dial, or the local health, public health agencies in the counties. These are things that just require, I mean, I can, our analysis and our math can tell you what trajectory we are on. We can tell you what's going to happen over the next 2 weeks to a month pretty precisely. But in terms of what's, which level one needs to be at and what that has the implications for the rest of the county and stuff, these are decisions that are made more at the executive levels. But I can tell you exactly what the math is saying. So that's what we're going to focus on here. Okay, just FYI, in case you're not sort of looking at what the Boulder County is doing, we're currently in the orange safer at home level. So pretty high risk, but still trying to make sure that the economy is moving forward and such. Okay, so figured I'd just give you a little bit of history of where we are and why mathematics and mathematical modeling and computational models have become so central to the sort of dealing with this pandemic. And part of the reason is that we've had them for over, well, basically 100 years is really where this came from, in the aftermath of the malaria epidemics and flu pandemics in 1918 and to 1920 in that region. Two people in the British Empire, Kermack and McKendrick, published a sequence of papers in the late 20s and early 30s, where what they did was took a general population and then they partitioned it into basically, what is your relationship with this disease? Are you susceptible? Are you infectious? You have the disease, you can transmit it to other people, or have you recovered, or are you? They called it immune at the time. Of course, there's all sorts of diseases where one can recover from, say, the common cold and still and not be immune. So you go back to the susceptible category. But this was the framework that they started with. And as I said, we've had it for a while. This was the original model. If you've taken a differential equations class, or not, I mean, these equations describe how things flow from one compartment to the next, one compartment of susceptibles to infectious. And it's, if you sort of look at it, so S dot means the rate of change in time. So how does it change in time? And there's an infection rate, how many contacts are resulting in infections, scaled by the total population. So you divide that. And then you have, the number of susceptibles goes up, your infection rate goes up. The number of infectious goes up, your number that should go up as well. And so you see the minus here, you leave the susceptibles and you join the infectious category. And so basically just flow from one place to the next. And then there's a recovery rate. And if the recovery rate goes up, then your flow from the infectious category to the recovered category, well, that flow should go up too. So hopefully the rate with which you're producing new infections is slower than the recovery rate, so you can sort of try to get ahead of the disease. Is sort of one of the, I'll talk about that in a minute, but this is where all of this came from about 100 years ago. And so as you can imagine, people have been very interested. There have been a large number of pandemics, flu pandemics and other, obviously SARS and MERS and all these other diseases that we are unfortunately becoming more aware of. And people have been modeling these. And this is like, from your physics classes, this is sort of the F equals MA, right? Things start here, and then you have to incorporate more and more realism and add other features to the models as you go along. But this is really the core basics of what a lot of the modeling out there does. And so, well, let's focus on the picture so you can just kind of see what happens. This is the basic model, and you start. This is just an example where, say, you start with 500 people who are susceptible. You start with 0 people who are recovered, and then you add 1 infectious to the population. So it's actually technically 499 people, but and so this 1 infection creates an infection wave that peaks somewhere around 240, 250. The number of susceptibles drops as more and more people become infected, but then more and more people get recovered, and so eventually everyone who's susceptible passes through the infectious to then become recovered. That's obviously a very simplified angle on thinking about these things, but this was the core of the epidemiology, is coming up with the math that starts with susceptible, goes to infectious, and then become recovered. Okay. This is sometimes people find it more interesting to think about this in what was called a phase plane. So if you plot susceptibles versus infectious, you can think about this starting in the lower right-hand corner with one susceptible and 499, one infectious and 499 susceptible. And the curve actually, you go up, there's the peak of your epidemic where you have the most infectious and most number of infections, and then it drops down to 0. So yeah, so you can sort of even see like a broader view of this. And the arrows here are coming from math analysis here, but basically you can just follow the blue curve, and that's what a infection or an epidemic looks like, right? From a mathematical perspective. Okay. So the whole analysis here, and this is something that I bring this up because this is something that you will see in the news. Governor Paulus, in one of his early press conferences, actually talked about this. It's this idea of a basic reproductive number, and it tells you, it's called R naught, R0. So if you see this in your newspapers as you read them, this is the discussion of basically how many people, for an individual who is infectious, how many new infections will be caused over the lifetime of when that original person is infectious. Okay, and so you can think about this very, I'll talk about the math in just a second, but just very intuitively, the number of infection-producing contacts per time the infectious period. That tells you how many new people will be infected by one person. Okay, and it's interesting because on the right here, this is from epidemiology that says, okay, well, that seems logical to come up with how many people are being infected and then times the duration of when you're infectious. If you go back to the math, you get this comes out as exactly the same analysis, and all it says is, will the number of infectious people go up, right? If you're over here, sorry, let me go back one more. If you're over here, you start your pandemic here, well, you're going down. So it's not quite mathematically that interesting, right? And it's sort of hopefully more from society, it's helpful because you're decreasing. What you care about is when you're on this side of the peak, are you going to go up and have more infections? And it turns out that sort of the epidemiology concept of R naught, of this reproduction number, is identical. There you can come up with a math formula that has the same thing and says, will the number of infectious increase over time? Okay. I'm happy to answer questions about that if there's stuff popping up in the chat at the end. I can come back and talk about this. Basically, yeah, as I said, number of susceptibles and infectious will infect over their lifespan. That's sort of this number. It changes, over the course of the epidemic. If we think about, later on, there may just be fewer people to infect. So as the number of susceptibles goes down, this whole number should decrease. That's sort of hopefully an intuitive concept that if there's less susceptibles for whatever reason, whether there's because there's a vaccine or people are quarantining, your reproductive number should be lower. Right? There should be less people to infect, so there's less possibilities for infections. If you're interested in such things, there has been there's 100 years of development of these models. There's a nice, Herb Heathcote talks about this, and they have ways to incorporate when you have an incubation period where you've just been exposed, but you're not yet infectious. There's ways to incorporate vaccines into these models. Quarantining, if you sort of think you might have been exposed, it removes you from the or you don't want to be exposed, you remove yourself from the susceptible population. Isolation, if you already have it, you need to remove yourself so you're not infecting other people. And all of these, passive immunity, there's obviously the other diseases that, there's maternal, antibodies that get transmitted. And, we all are familiar with the common cold where you can get it again. And so instead of just going from susceptible to infectious and recovered, you go back to susceptible. And so the important thing I'm saying here is just, we haven't, as applied mathematicians, we have not just been sitting on that original model for the last 100 years. There have been all sorts of features that are very realistic and happen in real pandemics that we've been there are ways to incorporate those into the math. Okay. So what I want to talk about here is this is what the Imperial College model is. Neil Ferguson was the person who was in charge of this particular group, and this is what they came up with back in January. And they, you can just sort of see this is the forecasting forward that if we do nothing, March, May, June, there's going to be a peak of how many critical care beds do you need if you nothing, and this is per 100,000 of the population. And you can look at this, and then you can go to in the UK, the National Health Service, and you can figure out how many beds are available. How many beds would there be even if we had a surge of reducing the number of elective surgeries, if we just had all the beds being used for hospitals. If somebody needs a ventilator and they don't get it, the outcome is almost 100% fatal, right? So if you only have, say, 100 beds per 100,000, of course that's not completely true, but the numbers, basically, if you go above a threshold, right, then everybody above the threshold is not going to make it, and even those below the threshold, there's 50% chance that they're not going to make it, at least at the time. This was sort of the idea. And so what the group did, of course, was they looked at what happens we do nothing. What happens if you have some sort of case isolation, household quarantining, general distancing, closing of schools, and they tried to just do thought experiments of what would happen. And each of these, for the UK at least, here's their surge critical care bed capacity is actually down here. And so the whole idea is if you cross that, you're not going to have good outcomes. You're going to have a large number of people, and predicting 500,000 deaths in the UK and over 2 million in the US. And obviously we've all read the news. We're at 230 or almost 240, I guess, is the current numbers. And we hope that we'll be able to keep that down. But that's what it is right now. We're lower than the 2.2 million right now. Is pretty much what we can say. Okay, so that's sort of the bigger picture. That's where we came from. We have some mathematical models. Of course, integrating all the data, merging it together, and it's basically, communicating with stakeholders, right? The different health systems in the state, the different, the different public health agencies. There's a lot of moving pieces here to try to make sure we provide the best and most accurate information for the governor and his staff to make decisions. And so there's a lot of people that have been involved in this, including the Dean of the School of Public Health, John Samet, who was the leader of this whole group. Many people over in the School of Public Health, in the School of Medicine, obviously myself in Boulder, some people from Denver, CSU, and then the CDC contact there. But these are sort of the list of people. We have these, these people we're meeting with every week to make sure these things go forward. So, having said all that, where are we now? What's going on? Well, I can't really candy coat it at all. This is not where we want to be. Okay, that's at the end of the day, just not where we want to be. So, and one of the things as I'm talking about this, there are you have to keep in mind that when you have a model, if you want to make sure it's accurate, that means you have to match it to some sort of a data, right? We have knobs in the model, parameters that you can change that will create different outputs, and those different predictions in terms of the case counts, in terms of the hospitalizations, in terms of the deaths. And so what I want to show you and go through here is what you can find online, and what we actually ended up using in predictions for the model. So first, this is the case counts. And as you can see, the case counts start in March, and as we go along, there's sort of increased growth, and then it looks like September, October, November, we are on a quite a steep incline here. It has been very difficult, and a lot of the a lot of the modeling around the country and various, there's various institutes, the CDC, it is difficult to calibrate your model to cases precisely. Partially, the reason for that is that there is so much variability of why people get tests, where they get tests, what the criteria for getting testing was, that, this looks like a nice smooth curve here, but it becomes really hairy when you try to nail things down precisely. And I mean, there's many cases. There was a situation back in September where there was in one county, they had a huge spike in the number of cases and the number of tests and the number of positive cases, because it was right on the border with another county where there weren't any free testing sites. So the question is, does that tell you that there's a spike in which county, and trying to tease that out? It just is really, really gnarly. There was even a situation where there was a miscommunication of a data format. And so at some point, I don't remember I think it's there's one bump here. Basically, a health service provider finally got the communication correct with the state of Colorado, and then all of a sudden 15,000 tests came into the system on one day. And so it looked like there was a bump, even though it wasn't really a bump if they had used different reporting dates and had their corrections. So cases are the best interpretation you can say is if they're going up, you probably have things going up. But in terms of how bad they're going up, it becoming really precise about it, getting more than sort of a up or down, it's just challenging to deal with the data on this one. It's just there's so many moving pieces that can bias you in different directions. Unfortunately, there's a lot of problems with using the deaths, and there are models out there and people who are the directors of modeling institutes that get interviewed on CNN where they leverage everything on the deaths. And so the question is their models, what are they doing? This is also problematic because there's questions of whether or not, did the person, was it, a fatality from specifically COVID? You get lots of, senior citizens, and then there's just a question of, is it just a co-infection? Is it a contributing factor? And it's not to say that, the deaths that you see here, these are confirmed people who did have COVID, but it just becomes a little bit, again, it's sort of statistically, if you're trying to nail down exactly what's our infection rate or what's the basic reproductive number, you have confidence intervals that, you might go from, say, 1.2 to 3 or something. It's just, it becomes, you can say it's bad. You can say it's going in the wrong direction. And we know that it is, but more than that is a little challenging. And so here is one of the most forward and wisest things, I think, that the modeling team that we did is that we used hospitalizations as our metric for the comparisons with the output of the model. And so what this is hospitalizations over time, and we were using the darker teal. This is confirmed COVID. This is I took this off the state of Colorado's website. These are persons under investigation, and so this upper part, they can actually end up in this lower part. But so the teal curve is the one that I want you to look at. That is the curve that we were looking at in terms of the output from our model. Does it match that? And obviously you can see here, starting in mid-September, things just started to go sideways or up. I guess is the way to think about it. We did have this bump back in mid-July that we're pretty confident that came from people having July 4th parties. And so you can see there was a bump about a week to 2 weeks later, because that's how long it takes for someone to becoming infected to ended up in the hospital. That's the time period. And so the criteria for test for someone getting in the hospital has been fairly consistent over the entire pandemic. And when you have that type of consistency in the criteria, the statistics work. These just really are the most reliable. And so we are very confident about, when we fit this, it's good. we're pretty happy with this. But the other two, and that's not to say that you can't extract information from them, but we think that what we're doing is a much more rigorous thing. Okay, so yeah, that's I think that's all I wanted to say here. So okay, so the existing models. Well, so there's a lot out there. You can go on the web and you can find all sorts of different models that come from different places. The compartmental thing with this exposed category that we're using, we're one of them, where University of Colorado is one of the SEIR models. Purely statistics models, where this University of Washington, IHME, they leverage a lot on the deaths, and they try to, even though there are questions with the how precisely accurate is it, a little bit above or a little bit below, they have tried to account for that in their models. And then the Imperial College has their model, and then there's another Institute for Disease Modeling. So these are all different ways to extend those original ideas of Kermack and McKendrick from the 20s. And we have chosen one that's that we feel is the best for Colorado. So this is the model. This is exactly what we do, is we watch and we say, okay, we start with everybody in Colorado is susceptible, and then we have a few infectious that come in basically January, February, and they start transitioning susceptibles to expose. And of course, as we all know, this is the insidious part about this, is that there is a huge fraction of people who become exposed who then are infected, but they're asymptomatic and can transmit it to other people. And there's just, if you're asymptomatic without an actual test, you just don't know. Symptomatic, there's a very, there's sort of most people that become symptomatic. There's a nice sequence of symptoms that come up. I think it's fever is the first one. And then you get to aches and nausea and stuff like that. And that's sort of different than the flu. So you can actually distinguish between them, but not everybody has it that way, but that's the majority of them. And then from symptomatic, of course, if somebody has like the sniffles, well, they can go straight to the recovered. They're not that bad. There are people who become hospitalized but don't need an intensive care unit with ventilators. And then there's people who, of course, go for the ventilators. In our experience looking at the numbers, it was negligible, the numbers that sort of went from symptomatic, recovered, and I don't know that we actually had anybody that died after that that we could tell from COVID. And the non-ICU hospitalizations, it wasn't enough to impact the mathematics. And so pretty much this is right here, is if you're in the ICU, there's a definitely notable chance of dying from the disease as it gets into your lungs. And Andrea Buchwald is a faculty member over at CU Anschutz, and she's the one that did some of these pictures here. So actually, I was just going to. Is there any? Was there any questions from the chat about this? Because this is the core of what Colorado is doing right here. So I was just, if Laurel or Amanda had any, if there's anything from the chat that was appropriate for me to talk about here.
Yeah, David, we do have one question. If recovered loses their immunity after X amount of months, and that comes from Richard. Okay, so that's a great question. It's one of those things where we don't know. There is basically there are a handful of cases around the world where people have been reinfected with COVID. I've dived into a few of those case studies, and it was people that had. There was one in particular I was thinking of that was it was difficult to draw conclusions from, because the person had a super mild case, and then they had to go on cancer treatment, and so they were immunosuppressed. And so it's like, I don't know if that's really something you can draw conclusions from. But at the end of the day, the virus is mutating. There are papers and evidence of, how long immunity lasts, but they're going along with how long we've known about this disease. So right now there are some articles that I've seen that say, well, we have 6-month immunities or 3-month immunities. And as we go along, we will discover if that continues, or if the virus mutates, and so we don't have those things anymore. Right now,
there is not evidence that someone who is recovered is going to go back to the susceptible category. So
thank you, David. We had one more question come in from Sandy. Is there a part of the exposed population which is neither infected asymptomatic or infected symptomatic?
So you should think about the exposed category as an incubation period. So so there's sort of think about these, each of these categories like waiting in the line, right? So you start in the susceptible. If you get infected, then you step over into the exposed category, and then you wait there until your immune system has kind of lost the battle, and you have enough virus in you that you become infectious to other people. And whether or not you have symptoms, that's how you split between those two categories. Does that make sense?
Yeah, that's great. Thank you, Dave. That is all the questions at this time.
Okay. All right. Great. Okay. Well, let's move on then. Okay. So I'll throw this up there because in case people are interested. This is the core of the actual model that we are using. It's a compartmental differential equation model. But the one thing I want to draw your attention to, so the rest of this is just details. It's like, how long did somebody spend in the hospital? Well, on average, they spent 8 days there before they leave, and that's where the 8 comes from. And I can talk through all these things, but it's really the core issue. Is this up here? So this is beta is the transmission. That's the number we want to make sure that sort of is, it's a problem, right? If it's a big number, this means that you have more people becoming infected, moving from the susceptible to the exposed category. And so what you want to do is this TC, this is transmission control. And one of the big issues and sort of elephant in the room is what goes into transmission control. Okay, I can tell you that right now, Colorado seems to be about at 60% transmission control. So we're doing better than 60% reduction in the values that we were seeing in February, March. Okay, but of course, you have a question of policy. Like, what does that mean you should do? Like, how much does social distancing impact that? How much does mask wearing impact that? And one of the problems, especially during the first few months, is that we didn't know what was the best way to stop transmission, and so they tried everything all at once. And so what component of transmission control was masks? What component of transmission control was distancing? What component of control was shutting schools and virtual and working at home? That was, and people not going to restaurants. All of those questions are important questions to ask. And it's a problem because we can't, at the time, and only up until recently, we weren't able to answer them at all. We could just say, well, we have to get it, we can't just have 60% transmission control. We have to have 85 to 90% transmission control in order to get the disease to go down. And so it's over time, of course, different municipalities, different countries, states, any level of government have chosen to do different types of non-pharmaceutical mitigations, right? And so with that, there is actually, these are, for lack of better to say it, these are experiments that are being run that have started to allow us to tease out the relative importance of these, each of these features. But before now, it was really, there was lots of assumptions to try to make conclusions about that. And we did the best we could with evidence from, trying to draw on what happens with the flu and other, colds and other coronaviruses and other airborne transmission diseases. But we are, acquiring much more accurate information now. And I'll actually show a slide from a paper that was just published in Science, I think, like last week. And we'll talk about this, but this is the part right here, is you want transmission control to be as close to 1 as possible. So this whole term multiplies together to be 0, which means you have 0 people leaving susceptibles to go to exposed. Okay. So I'll go through this a little bit faster. It's in case you are curious about the mathematics of this. The previous computation I did with R naught, that's just for the very simple model. We have now a much more complicated model. And if you're interested in this, sort of the way you think about this is you start doing, how do you do the R naught for systems where you have exposed categories, both infectious and asymptomatic. You just kind of collect everybody together who is on the way to being infectious or is currently infectious. Collect them together. You can, collect them all on a big vector X, exposed, infectious, and asymptomatic, and you can actually create a system. And I can go through this slower if people are interested, but I didn't want to do it too fast. But anyway, you create a system here, and if you remember your differential equations class, you're looking at you're looking at eigenvalues of this matrix. That's sort of the end of the day. How are things flowing through the system? And instead of just computing a simple is it greater than 1 or less than 1, a ratio computation for that basic reproductive number, you have to do an eigenvalue computation. But again, it's still less than 1, equal 1, or greater than 1. So it is the basic reproductive number. But I did want to show you this, and this was something that we played around with earlier, just to sort of give you an insight about what the math is actually telling you. And this was when we were using the social distancing, so it's kind of a transmission control surrogate here. As you change this between 0 and effectively 100%, you can see that this is what R naught is being computed for your system. And if you have 0 transmission control, you have R naught at 5, which means every person infects 5 other people. That's bad, right? But as you sort of distance more and more and more, it decreases. Actually, this is a straight line. And right around 80% social distancing or transmission control, it goes to 1, which means one person is infecting one other person, and that's it. And anything below that, you get less than 1, which means that on average, 2 infected will only infect like 1 person if you have a down arrow at half. And so that's great. That's the situation you want. But this is a very concrete picture that we can show to the Colorado Department of Public Health and the Environment. Says, look, we need some sort of transmission control that's high to make sure that we don't have exponential growth of the infecteds. Okay. I throw a bunch of these up here, but it's not that critical to even to look at this. What I'm just trying to tell you now is this line up here, the first line. We've broken down the population by age group since it's really, it's important, right? I mean, people who are 65 and above have different risk profiles. People who are 50 to 64, they're a little less risk profile. 20 to 49, lower risk profile. 0 to 19, in terms of being hospitalized, these are not people that are being hospitalized much. And we have to, the red things are the specific numbers that get adapted for each age category. But in general, that's the take-home message from this page, is that we broke up each susceptible, each infectious, each exposed into different age groups based upon demographics and such. So again, you can do the R naught value. It's the number isn't important, but it's sort of what I'm trying to say here is there's math behind this that gives us the guidance that having a high transmission control is important because we can control things. Okay, so here's the big picture that we're so excited about. Of course, is that as we look at how transmission control has changed over time, we're able to fit the hospitalization data really quite well. Usually we're getting, as you look 2 to 4 weeks in the future, if you take, say, any date here. So if you took May 28th and then looked at how the trajectory went, we're able to, by fitting the data up to May 28th, give a prediction of how things go for roughly the next 2 to 4 weeks. So that they have an idea up. Even here, we can see that things are starting to change and that we're going to be bottoming out in the near future. And so that's the type of information we're able to provide for the governor and such. And as you can see, here we are, second weekish of November, and we have not gotten up to barely touching the peak from April. We are plowing straight through it, and we are headed on a very very steep exponential growth part of the curve. So not where we want to be. And it's sort of, at the end of the day, it's also, you don't really need the fancy math to look at this and say that's bad. Okay, we need to think about where are the outbreaks, what is actually causing this, what are the best interventions that we can have, because the vaccine, while they've announced it and looks incredibly promising, there's just logistics of getting it distributed to people who are the most risky first, and moving from there. It's going to take it's not going to be Christmas, right? It's going to be March is when you're going to start to see these things getting to the general population, is my understanding. So one of the things that I thought just might be interesting to show, and this is actually, we have biweekly reports that are posted publicly. So you can see all of everything I've been talking about. Those equations are all public. All the pictures are all public. You can see exactly what we're doing every so many weeks. And this is actually the basic reproductive number, how it has changed in time as the transmission control has changed. And it's I didn't smooth this. This is, when we estimate these things, they estimate how transmission control is over a 2-week block. And so you can see early on, there was 0 transmission control, and we were up above 5 new people being infected for every person. And then as the governor put in these stay-at-home orders and such, it started dropping as people, as sort of people got really serious about this, and the school is closed, people kind of just were able to be outside for exercise and stuff. We were doing quite well in the May to June, and then there was a little bump that sort of presaged or predicted that we were going to have a peak coming in mid-July, and then it went back down. And since then, since August, it's sort of just been slowly creeping up, and we're somewhere right here. But one of the things that I want to point out is that you see, and I just ran this forward, basically the effective R naught starts to drop as the number of susceptibles drops, right? And so you're like, oh, this looks great. By December we should be having R naught 1, less than 1, mid-January. That's great, except I'll have to sorry, I'll come back to what's going on. So keep that in mind. There's this is an advertisement for just a little bit in the where we're headed section of this looks really good, that we should be doing great in mid and late December. There's a caveat here, and so I'll show you what's going on in a minute. I did want to mention something because you'll see a lot of discussion about this in whatchamacallit, because this is sort of the Swedish approach, was to sort of let the virus run through the population without really having as strict of lockdowns as a lot of the rest of the world and the country. And so there was a lot of discussion of this concept called herd immunity. And what this means is, at what point are there so few infected people left that your disease will just disappear, okay? One of the problems with this is that when you go to compute this, and if anybody really is interested about this, I can point you toward how this computation works. But so these are the R naught, the basic reproductive numbers above 1. With a basic reproductive number of 5, we would have had to have 80% of the population be immune in some way. So that's sort of, and I say immune broadly, as in they've been removed from the population by quarantine because they're wearing face masks very tightly, and they're just not possible to be infected, or they've already gotten the disease and they're now biochemically or whatever medically immune. But so this is where the disease started, was up here, and so we need to have 80% of the people. And if you think that's everybody, 80% needs to get it, well, there's going to be a substantial loss of life if you want to deal with the disease that grows this fast, and to sort of be able to extinguish it by having herd immunity. As you get down here, lower, then it's not quite so bad. But if you're here, does that mean you're enforcing that you're here by people wearing masks all the time, or is it because they have enough the vaccinations, whatever? But as there's still a lot of people. I mean, you think about 6 million people in Colorado, and if 30% of them have gotten it, that's a lot of people that have had to go into tax our medical system, and large numbers of people dying. So it's still not a great scenario. So, okay. So with all of this, I guess I'll stop. Is there any questions before I go on the where we're headed part of this?
David, not at this time.
Okay. All right. I will then. Where are we headed? Well, here's the problem. So as you saw in that one picture previously, where that R naught dips down below 1, the problem is not so much that R naught has dipped below 1 and how great that is. The problem is that the trajectory we're on to get there. Because remember, R naught's when things start to decrease just because of the number of people in the population who've had this. And what you're seeing here is, well, first of all, the red was the peak from April. We're obviously plowed right through that. The last date that I had data for was November 9th. And I made this picture then. And so based upon how well we fit the data, we're able to create a projection that's uncertainty. Basically, we can say, okay, how well do we fit the data? We can kind of say, well, we're really this amount of uncertainty in the transmission control, and then we propagate that uncertainty forward. And you can see, though, that if nothing changes in the transmission control, if we all keep doing exactly the same thing we've been doing, this is going to peak in hospitalizations around 6,000 hospitalizations before it decreases, and possibly, up to almost 7,000. There's 10,000 beds in the state. And so that's a lot of people in hospitals, and our drugs and therapies, the medical therapies, everything from the remdesivir, we're getting a lot better, but having almost 7,000 people hospitalized when your total capacity for everything from broken bones to dialysis to surgeries is 10,000, that's a very worrying number. Okay. And we were all worried back over here when we were at 901 hospitalizations at one point was the peak. So this is R naught's less than 1 at this point. Well, it's going down, and it's going down from the 6,000 level. So this is why the governor is making comments about about restricting in Boulder County about numbers of people you can have in gatherings, and numbers of people that can be in restaurants and such, because we don't want this. Okay, these are the pictures we show them, and they're very worried about it, and so they need to make policies that turn the corner here so this does not go that high. Okay, but one of the things that needs to be very clearly understood is that from the moment someone's infected to them being in the hospital is on average about 13 days. So whatever happens today, we won't see the impact of it for about 2 weeks. So that's just something to keep in mind. And that's it's difficult to use other criteria, right? Even the testing, because there's been so many lags in testing and reporting and communications with the CDPHE. So this is really the best data that we have, and this is the projections that we have, and so that's what we're dealing with. So I'll do this picture, and then so I also wanted to tell you that we are the state modeling team has been doing local public health regions. Okay. And so you end up breaking up with basically the white, ignore the yellow one, I don't remember what that one's for. The white boundaries are the regions that have the most in common in terms of their medical services and their medical services needs. So obviously Metro has a lot in common with itself and such, and then there's obviously you can see all these other different regions, but we've actually created sub-models for each of these regions, because of course somebody that's in the Northwest, they'd really like to know, whatever's going on in Metro, is that actually going to impact me? Maybe during ski season it might, but right now, do we actually have to have draconian lockdowns in place? Because how much of a connection do we have with the overall state model? So there's a very valid, reasonable questions asked, and so we've been doing this, and unfortunately, nobody's really in a good place right now. San Luis Valley and the West Central Partnership, those were the ones that were doing pretty reasonable. In September, they were actually, West Central was in below 1. That was great. Central Mountains, East Central, great. excuse me. But pretty much since then, September, October, we're all in this, between 1 to almost 1.5 region, with South Central actually creeping closer to 1.5 to 2. And so this is it's a problem, right? I mean, there's definitely over time you can see moments where certain regions like the Central region was doing much better than, maybe other Northwest was doing really well. But, we fit our model to these local regions, and this is what it's telling us, is that South Central in particular is the one that's got a problem right now. Okay. And this obviously was of great interest to each of these, the local counties and the regions. And this was sort of helping to inform how, you implement the dial and all these types of things. But it's sort of it's a more mathematical analysis of that. One of the things that is sort of where we are headed in terms of analysis is that a lot of these cell phone companies, Google, Apple, what they have started to do is take aggregated data. So not like, tracking people individually, but taking, in sum, where are the flow of devices? Because usually people are, holding onto their cell phones. And it's interesting here. So this is looking for Colorado, basically looking at cell phones. You can, in aggregate, again, tease out walking, driving, or riding mass transit of some sort. Well, you can see back in January, February, pretty much people were doing things that were on a, I think these are weekly timescales or something, why it's up and down. But then pretty much come March, all movement of the cell phones kind of just dropped off. Slowly that has crept back up. And this is sort of, now it's sort of drifting a little bit back down as things are, getting worse and worse. But using transit has, pretty much stayed low. But these types of things can really help us inform how there is transmission from, say, the metro region to various outerlying regions, right? Knowing that the average flow between one region to the next can help you say, well, there's going to be some number of people who are infected who are flowing from one region to the next. It's not the whole story, though, right? I mean, that's what I said. We can't really. Previously, we were unable to tease out that transmission control from all these other features, social distancing, et cetera. Mobility helps us, try to tease out some things. Actually, I'm going a little over on time, so I want to talk about this slide here because it sort of ties into it a little better. So sorry, this is a Nature paper that just came out. Knowing mobility is great, but you also have to know what the density of risky locations is, right? So you can say, if I have, this 1,000 people or 10,000 people going from Denver to, Vail in some time region, Vail pretty much has people go out to eat all the time. And so that's going to be much different than people who say go to, Rocky Mountain National Park, have a picnic, and then drive home, right? They're not utilizing the local restaurants. But so this is one of the first papers I've seen that is now, and I apologize for the fuzziness, I cut it from a paper. But basically, this is giving you a sense of what are the additional infections compared to not reopening. So if you do go back to reopening, not reopening, where are the places that are the most likely to get you an infection from? And you can see far and away the number one is the full service restaurants, and then we have a cluster of fitness centers, cafes, hotels, limited service restaurants, and religious organizations. Pretty much, I mean, it's a log scale, right? And so you've got your top 6 places. And that's where you need to draw your attention to, right? And that's what's we're in the process of putting in the model right now. Is basically, because this data was just published like last week. But these are the locations, and it makes complete sense from the perspective that we now know it's a aerosol and droplet driven transmission. And so any place where you're talking, where there's saliva, where you're singing, these are transmission opportunities. Okay, there's a well-known case where there was early on where someone was sitting in front of an air conditioner, and everyone downstream from the air conditioner got infected because they were just talking like normal, and it just happened that the exhaust was blowing right by them, and the people downwind were the ones that got infected, and nobody else in the restaurant got infected. So it's really aerosol, it's air dynamics, and so you just have to these are the places you want to target for whatever mitigations or whatever you want to do in terms of making people wear masks in these locations or distancing, however they want to do it. This seems to be the highest problems, or the most problematic locations. Okay. So I thought I'd throw a little bit in here because I've also done done modeling for CU. And of course, as a university, it's a different situation. Okay, so I'm going to switch gears just a little bit because first of all, you have a very different demographic, right? 18 to 22-year-olds or 25-year-olds, I think, is the general category of people who are in college, graduate school, that kind of time periods. And not only that, CU has actually people in sort of the biofrontiers and I think in biochemistry have come up with a saliva-based test. Okay, and the return around for this test is incredibly rapid, but it's not just the testing. If you have rapid testing, that's great, but you need to be able to get people in isolation so they're no longer infecting people. So over the summer, CU built up a infrastructure to do so. And part of what helped to inform this was this analysis. I did a model for CU for the students, making some reasonable assumptions that based on other universities that had opened around the world, and you can figure out what R naught is relative to the lag between an infectious confirmed test and getting them in isolation. And it turns out that based upon our knowledge of how the disease propagates through people who are in the 18 to 25-year-old age group, if you can keep roughly your lag to isolation below 2 days, 48 hours, you can beat the disease. And detection to isolation is basically what they were going for, a maximum of 24 hours in the CU system that was set up. And there was actually a couple of cases where they were able to have a saliva test in the morning and the person was in isolation by 2 in the afternoon. So they were, this sort of knowledge of fast testing and fast isolation is really what allowed CU to control the epidemic as well as they have amongst the students that they had sort of ability to control. And you can see what happened here. This is from the COVID page. So if you look at this, let's start down here. So this is the isolation. I don't know if you can see, it's kind of small, but this is sort of August 24th, 25th, 26th, 27th, the 1st, 2nd, 3rd, 4th, 8th, 9th, 10th, and you see the sort of isolation going up and usage of that. Well, what happened was that a few of the Greek organizations didn't really listen to the recommendations of having the rush week online. And so they had in-person rush weeks, and there was some, it's sort of like no more than 10 people gathering, and they interpreted those as like no more than 10 people in the yard, no more than 10 people in the house, no more than 10 people on the second floor, no more than 10 people, these kind of interpretations. And so that rush week event caused an outbreak, right? And so, we were able to compute exactly, on the upswing, how bad this was going to be. And they ended up with, almost 300 people in isolation. But it was literally one outbreak that bumped and went back down. And it was sort of it was a picture perfect epidemic wave. These were the positive, the confirmation diagnostic tests. This was sort of up and down, and it was really all due to when they contact traced and they traced everybody back to the source, it was the fraternities and sororities thing. What you're seeing now over here as this sort of bump up, this is pretty much due to Halloween parties, which also, of course, was not recommended, but they happened. And so we have 2 people in isolation now, and we don't anticipate this going, much at worst, like 100 to 200, and it's going to come back down. It's probably going to peak around 100 is my guess at most. So the CU's response has been actually pretty reasonable. We've been able to contain things quite well. Now, of course, this is a very different population, right? The on-campus population, they're testing all the students once a week. So you have a lot, and they have very rapid tests. So this is not a general nothing that would work quite so well in the general population. There just hasn't been resources allocated to do that type of testing on that scale. So Promising developments. Basically, where are we headed right now? Reinfection is highly unlikely. That could change in 3 months. I just, right now the evidence says no. Okay. There's a lot we've learned, right? University of Chicago study saying the nasal cannulas are effective as ventilators. The person just needs more oxygen. Okay. There's promising medications. There's some other viral drugs that are coming out. There's some antigen type things. And of course, the Pfizer vaccine is the big news that was just announced that they're moving forward with. So these are all very promising. That is suggesting that we will be able to deal with this. The next few months are not going to be good. I don't know what else to put. I mean, you can listen to Dr. Fauci on the news as well as I can, and that's just the way it is. We really need to keep transmission down until the vaccine comes online and widely distributed. So, conclusions. We have a math epidemiology model for the state, created, coded, and validated. It actually keeps track of some structuring for the ages based on census properties. And then it's being used, it is, every week we have meetings with the governor and a briefing. And then he has his press conferences and such where he talks about how things are being integrated with, from our team, from the econ team, from the finance team, everybody try to make wise decisions for the state. I don't know how to say it, wear masks, right? This is an airborne disease. And it's, again, how Dr. Fauci said it, I don't know how this became political. 100 years ago, we wore masks to, deal with the flu pandemic. And this was that's just the way it worked. We know this, and it protects you, it protects other people. Just got to do it. And then the rapid turnaround testing at CU saved a semester that we were able to have, for the most part, in-person classes. And there was no cases of transmission to faculty. There was no cases of transmission to staff. And we have not been able to find cases of transmission to the general public from CU students. So it may have happened, but we haven't, our contact tracing has not been able to find that. So finish with acknowledgements. Obviously, Governor Paulus for being a data-driven executive and politician has been very, it's been exciting to be working with them. It's been a wonderful partner to work with. Public Health, CDPHE, Colorado Health Association is a group of hospitals that have also supported part of this work, and the modeling team. My graduate students have been kind and not complained too much when I've gone off to have to deal with this stuff. I even integrated this into a math biology course in the spring. I'm going to do the same thing in the spring also. And then my wife, Vanya, has been very kind of letting me spend a lot of time on this. And then my 3-year-old, who only has a few times said, "Daddy, get off the phone." So, all right, that's it. Thank you.
Thank you, David. Due to time, we're going to jump into 2 quick questions. Our first question is from Stephen. Mm-hmm. With respect to herd immunity, what happens as the virus mutates? Does that just restart the spread and the herd never gets immune?
That's definitely a possibility. It's of course a question of what what mutation is happening, right? Is it making it more infectious, less infectious, more catastrophic for the people who get it? You're completely right. It changes that dynamic if you start changing the properties of the disease. So yeah, I don't have anything deeper to say than that. It's yes.
Thank you, David. Our last question comes from Christian. Curious to know if it's possible to estimate a projection for spring/summer 2021 at this point in time.
So one of the things that's important and is pretty critical in terms of just the science and both the public relations of talking about this is that there are projections and then there's forecasts. I would be very hesitant to make a forecast, which is kind of like what a weather forecast says. Here's, say, the cone of where a hurricane is going to hit for that far in advance. I'm, very comfortable doing that toward, the end of the year, even in the beginning of the year. We can definitely make projections, and in several of the reports, we've actually run the simulation, far out. But, we don't want to get near the 7,000 level of hospitalizations. And so something's going to change, right? They're going to put policies in effect, or there's going to be public health orders, or recommendations, people get distributing masks, so something is going to change to try to prevent it going that high. And then, of course, then the math changes, right? Has to account for that. And so it's very difficult to predict what the governor exactly is going to do when he's going to do it. I can tell you, if you keep if you keep your transmission control at 90%, well, it kind of just goes away. If you let it sit at 70 or 80%, the peak will happen later. It will be a little bit lower, but you're still going to have a lot of people become infected. And I don't have a plot to show you, but we've definitely looked at those. It's just it becomes a projection as a thought experiment. The further away you get, rather than an actual forecast.
Thank you, David. Thank you so much to everyone for joining us for today's presentation. And again, thank you to David for this great information. At this time, we invite you to provide your feedback on the webinar by answering the following poll question. On a scale from 1 to 10, how likely are you to recommend this webinar to a friend or other CU Boulder alumni? We thank you in advance for submitting your feedback. As a reminder, all webinar attendees will receive an email tomorrow with a link to the recording of this presentation as well as a survey. To view upcoming webinars as well as previous recordings, please visit our website at www.colorado.edu/business/alumni. We hope you will join us for our next webinar, which is December 7th, as Associate Dean for Business and Government Relations and Senior Economist, Dr. Rich Wobekind, and Kelly Bra, President and CEO of the Denver Metro Chamber of Commerce, presents on the 2021 Colorado Business Economic Outlook Forecast. In the meantime, have a great rest of your day. Thank you for your time, and go Buffs.